Thank you, Aaron, for that generous introduction. And any time that anybody's compared to Arch McNamara, that's an incredible compliment. Mark and Dr. Kaiser, I appreciate you guys inviting me here and being part of this great program. I want to tell you how honored and humbled I am to be here to give you the third annual Arch McNamara lecture. As I was in preparation for this and reflecting on giving this lecture, I was really struck with the fact that I wish I wasn't given, that there was no reason to give the McNamara Memorial Lecture, or that maybe the first McNamara Memorial Lecture would be in 2040 or 2050. And when you think about Arch's tragic death, it's impossible to make any sense out of it. And it's hard to believe that a class of retina fellows here at Wills finished the program, the class of 2013, and didn't have Arch as a mentor, direct mentor. But obviously the way Arch trained many of us and many of the people on the retina service, they were still trained by Arch. When I start getting sad, think about Arch, the man and the friend. He wouldn't want us sitting around here being sad. He'd want us to celebrate his life. And so I'm happy to be here as part of that. Oops, I guess that's not how you do it. This is a picture that I proudly display in my office back at Wake Forest of the Band of Brothers as it existed back in 1988. This is from the Retina Society meeting here in Philadelphia. And you can see a young me next to a young Arch, flanked by a young Bill and a bunch of young folks. And we truly were the Band of Brothers. And the Band of Brothers is mostly different now, some of the same characters, but the brotherhood and the sisterhood of the Wills Retina Service continues to be strong across its 52-plus years. I want to say just a few words about why I admired Arch and why we all loved him. And Aaron touched on all of these things, but as you go along in your life, you have less contact with people who've been very important to you, so you lose touch. And that's just the nature of moving on. But I would always, we shared Christmas cards with the McNamaras, and at meetings we would always try to get together to sit down and talk. And, we never talked about ophthalmology, and we never talked about medicine. We talked about Judy, how much he loved her, and about the children. And it was just always just great to be with him. And the things I admired about him was he was a great husband to Judy, and he's a great dad to Kelly and David. He was all about family, and that was what was important to him. But he was an outstanding doctor and a surgeon, and he was a great teacher. You sometimes learn a lot from people who are just a little bit ahead of you, and he was probably one of the people who had joined the retina service before I got here. He was a great friend and just a great guy, and had a great sense of humor and kind of emotional intelligence that could fill up this entire room. So I'm really honored to be part of this gathering and to get the opportunity to tell folks who didn't know Arch what he was like, and to continue this nice tradition that you all have established of celebrating his life. So thank you for having me here. I'm going to talk about diabetic macular edema management in 2014, and I have no conflicts of interest in this presentation or anything that I'll discuss, but I will discuss off-label use of triamcinolone and bevacizumab for the treatment of diabetic macular edema. First off, it goes without saying that it's paramount importance that to control systemic health issues and actively manage them in taking care of diabetics. Blood sugar and blood pressure and serum lipids need to be optimized to get the best possible systemic and visual outcomes, and remember that no tobacco. Diabetic macular edema patients are sick. Diabetic macular edema patients are among the sickest. If you take patients with diabetic macular edema, they have 2.5 times the risk of having a heart attack than someone who has diabetes and is otherwise matched, and 2 times the risk of stroke. So these are among our sickest patients. We know about the pathogenesis. The final common pathway is breakdown of the inner and outer blood retinal barrier. And I believe that diabetic macular edema, with all the things that are coming at us, is the most complex macular disease to manage. And it's impossible to give just a simple or even a complex algorithm regarding the management of DME. But I'm going to review some of the clinical trial findings and how they influence management of our patients. And remember that each patient is unique, and we have to use clinical judgment in all of these folks. These are the clinical trials that I'll talk about, the ETDRS, the DRCR protocols, BI, and I'll mention T, the RISE and RIDE trials, the BOLT trial, and then the recently released VIVID and VISTA trials from Regeneron. Just to go about over classification, when we start, clinically significant macular edema, back in the day, the ETDRS defined it as retinal thickening less than 500 microns from the fovea, or hard exudates less than 500 microns from the fovea, or retinal thickening greater than a disc area within a disc diameter of the fovea. And for the ETDRS, this is what they used. Now, all studies are going to be talking about center-involved macular edema. These weren't all center-involved, but center-involved versus non-center-involved is certainly important in how we determine how we're going to manage them. And then there's this concept of focal versus diffuse that is somewhat of sometimes arguments between patients, but depends on source of fluorescein leakage, extent of macular thickening, and pattern of lipid exudates and OCT findings, certainly. Previous management was simple because we had one nail, and that was laser photocoagulation. And today we're going to talk about, I'm not going to talk anymore about systemic control or vitrectomy, but I'll talk about laser and steroids and anti-VEGFs in the management of DME. So what are our goals when we're taking care of our patients with diabetic macular edema? Well, it's to maintain vision in eyes with normal acuity and improve vision in eyes with poor vision. We want to balance visual outcomes with treatment risks and treatment burden to the patient and the family. We want to improve the anatomy, and we'd like to have a cost-effective treatment. And so we'll talk about laser photocoagulation first, and we'll go back to the 80s and the early treatment diabetic retinopathy study that showed that laser, when compared to observation, improved visual outcomes in patients with diabetic macular edema. And these are the numbers from the ETDRS, where two-line gainers were 25% in the laser group versus 10% in the observation, and more patients lost vision in the observation group in the ETDRS than focal laser. And the average improvement with laser was about 4 letters, which we'll see with laser today, still about 3 or 4 letters, and with observation losing about 2 letters. One of the knocks on laser in the ETDRS was that only a small percentage of patients really improved 3 lines of vision. So now we're talking about 3-line improvement in patients with anti-VEGFs. But the reason that the majority of these patients majority of patients were 20/20 to 20/30 in the ETDRS, and they couldn't improve 3 lines of vision. And if you took the patients that could improve 3 lines of vision, 40% did improve 3 lines of vision. So we'll see that 40% is pretty good with the anti-VEGFs in terms of improving 3 lines of vision. So we all still see patients who were treated with photocoagulation back in the 60s and 70s, and I still see this patient who has 20/20 vision, actually, and was treated back in the 70s. Previous treatment used large spot size and high-intensity burns, and there's this problem of spread or creep and scarring and scotomas, and so hopefully we won't see eyes like this in the future, but you will see them. Current laser techniques, we use a modified ETDRS focal laser to areas of edema where we treat microaneurysms directly, grid diffuse leakage, and barely visible to light gray burns. And here's an example of a patient with pretty significant diabetic macular edema, center involved, you can see on the OCT, and you can see on the slide right, 9 months post-laser, the OCT is dramatically improved, and you can barely see any laser scars. So this is the endpoint that we're looking for now, and here's a picture of that, and you can pick out some light laser burns. So when do we use primary laser? It's a preferred initial option in patients with macular edema not involving the center, and a reasonable option in patients who have focal macular edema with center involvement if they have minimal foveal thickening or mild cystoid changes and no subretinal fluid. And here's an example of a patient whose fovea isn't involved, has good vision, 20/25. We treat them, and treating them before their foveal center gets involved makes a lot of sense, so we don't have to use such high treatment burden methods to treat. Just a pearl is it's better to treat diabetic macular edema before the center gets involved. And in patients like this, this is a patient who has mostly focal edema with exudation and got OCT changes, center involved, again, treated with focal laser photocoagulation. Vision was 20/60, and the central foveal thickness was 450 microns. And 6 months later, vision's 20/20. Laser burns are a little heavier in this patient, and the fovea normal, but the vision's considerably better. So focal laser photocoagulation is still a valid option in managing some patients with diabetic macular edema. So laser is still a great option, but you don't want to fry the retina. Talk about steroids and diabetic macular edema. None are approved for the treatment of diabetic macular edema. And in the early part of the last decade, many retina specialists advocated intravitreal steroids as a replacement for laser. A lot of the early work was done here at Wills. And there's this wow effect of intravitreal steroids with a dramatic, quick decrease in retinal thickness. And here's an example of a patient who was 2400 and diffuse cystic changes in the retina, and 4 weeks post intravitreal steroid injection, vision's back to 20/30. And how does it work? Well, they inhibit inflammation, they reduce vascular permeability, they inhibit fibrin deposition, they upregulate tight junctions, and they decrease release of cytokines and actually have an effect on VEGF as well. So, there was this debate back in the day whether laser was better or whether steroids were better. And I remember when we were planning Protocol B in Tampa, people would say, I'm not sure we're going to be able to get people enrolled in this study because we know that steroids are way better than laser photocoagulation. So, Protocol B of the Diabetic Retinopathy Clinical Research Network involved 3 arms of the study, one triamcinolone 1 milligram and 4 milligram to focal laser patients. Focal laser in patients with diabetic macular edema involving the foveal center. And what we found in this study of 840 eyes was that there was no visual acuity difference at 1 year in the steroid-treated or laser-treated eyes. And from 16 months to 2 years, the laser eyes had better visual outcomes. And, of course, there was a much higher rate of complications in the steroid-treated eyes with cataracts and glaucoma. And here's 83% of patients at 3 years who were in the 4 milligram triamcinolone group actually developed a cataract requiring cataract surgery. So before we leave steroids, I just go, because I think steroids still do have a role in the management of diabetic macular edema. We'll talk about Protocol I of the Diabetic Retinopathy Clinical Research Network. And this was a study that, well, let me go back. Oops, sorry. Randomized trial evaluating ranibizumab with prompt laser, ranibizumab with deferred laser, triamcinolone with laser, and laser alone in the management of diabetic macular edema. And one of the conclusions from this study was that in pseudophakic patients, intravitreal triamcinolone with prompt laser appeared equally effective in improving vision as ranibizumab and reducing retinal thickening, but we still, even though there's pseudophakic patients, we still have IOP issues. So it plays a role, and it's still in our armamentarium. And here's a patient with diffuse macular edema, vision of 2200, lots of exudates, lots of cystic changes. We got some subretinal fluid, central foveal thickness of 650 microns, and a single injection of triamcinolone and a couple of laser treatments, and the patient's vision comes back to 20/30. The foveal morphology improves. So triamcinolone does have a role in the management of pseudophakic macular edema. Over the past 7 or 8 years, the beneficial effects of intravitreal anti-VEGFs in diabetic macular edema have been demonstrated, and works because VEGF is one of the most potent vascular permeability factors, and it's been shown to be present in the vitreous of patients with macular edema and proliferative diabetic retinopathy. So Protocol I that we talked about a little bit earlier, I'll mention a little bit more now. There were 4 arms of this study: intravitreal ranibizumab with prompt grid laser, intravitreal ranibizumab with deferred laser to 24 weeks, intravitreal triamcinolone plus prompt laser and laser alone. And if we look at the 1-year results of this, these are the inclusion criteria. I'm not going to put it in for all the studies we'll talk about, but they're pretty similar. Visual acuity of about 20/32 to 23/20, central involved macular edema with OCT findings consistent with thickening of the center of the macula. And this is the type of patients that we usually see in these studies. If you look at them all, they're pretty similar. Average age is in their early 60s. 90% of them have have type 2 diabetes, and their vision is somewhere between 20/50 and 20/80. In this study, it was 20/50, with a central foveal thickness of about 400 microns. And at 1 year, the change in visual acuity with the laser group was +3 letters, like we saw back in the ETDRS. But in the ranibizumab and prompt laser group was 9 letters, and the 2 ranibizumab groups was 9 letters, and in the triamcinolone and prompt laser group was 4 letters. And that was at 1 year, and when we look out here at 2 years, the 2 ranibizumab groups, which are the kind of the turquoise and the orange, had better visual improvement compared to the patients who got laser alone or triamcinolone and laser. And here, if the patient had predominantly focal edema, the 2 ranibizumab groups did the best. And if they had neither predominantly or focal or diffuse or predominantly diffuse ranibizumab, the 2 ranibizumab groups did better across the board in all of these types of edema. But if you looked at, and this is what we mentioned earlier, if you looked at the phakic patients, the 2 ranibizumab groups did considerably better than the others. But in the pseudophakic group, the triamcinolone and prompt laser did just as well as the 2 ranibizumab groups. The median number of injections at 1 year in this study was 8, and in the treatment group, and 3 in the triamcinolone group during year 1. And from year 1 to year 2, it was 3 to 4 in the 2 ranibizumab groups, and 1 in the triamcinolone treated group. So there's still an ongoing treatment burden in these patients. To summarize, intravitreal ranibizumab with prompt or deferred laser had superior vision and OCT outcomes. 50% of eyes had substantial improvement greater than 10 letters, while 30% gained 15 letters. And the results were similar with focal grid laser was given starting at the first injection or if it was deferred. So monthly ranibizumab, and the endophthalmitis rate in this DRCR trial was 1% in the ranibizumab group. So it was pretty high. So whenever we think, oh, we can just inject an anti-VEGF or inject something into the eye, we have to remember that there are these potential complications that can totally alter the life of our patients. The RISE and RIDE trials were studies done by Genentech, 2 phase 3 randomized trials that got approval for Lucentis for diabetic macular edema. And again, there's about 750 patients in this study, and there were 3 arms with sham injection and Lucentis 0.3 milligrams and Lucentis 0.5 milligrams. It was a 2-year study. These patients got injections every month for 2 years. And if we look at the sham injection group, they had 15% improved 15 letters compared to almost 40% in the ranibizumab-treated eyes. Patients 20/40 or better, 36% in the sham-treated and laser-treated eyes, and almost 60% in the 0.3 milligram ranibizumab-treated eyes. So the study met the primary endpoint with 39% of patients improving by 15 letters in the Lucentis group compared to 15 in the sham group, and there was rapid and sustained improvements in both vision and retinal anatomy. The BOLT trial was a 2-year prospective randomized trial of intravitreal bevacizumab or laser for diabetic macular edema. This was done at Moorfields. 24-month data I'm going to present, and there were 80 patients. Visual acuity, again, the parameters to be involved in the study was vision of 20/40 to 23/20, center involved, and patients were randomized to bevacizumab or laser, with the main outcome the difference in best corrected visual acuity between the 2 arms, and the secondary outcomes that we've looked at before, 3-line gainers, change in central foveal thickness. Sorry. Following 2 years, the mean visual acuity in the bevacizumab-treated eyes was 20/50 and 20/80 in the laser group. Mean gain of about 9 letters in the bevacizumab group. We've seen that before, versus less than a letter for laser. And 49% gained 10 or more letters versus 32% gaining 15 or more letters. And the median number of treatments was 13 over 2 years for the bevacizumab-treated eyes. This is relatively recent data. VEGF trap or aflibercept is not approved for the treatment of diabetic macular edema at this point in time, but these studies have, the VIVID and VISTA, VIVID is ex-US and VISTA is here in the United States, again, entered patients with type 1 or type 2 diabetes and best-corrected vision of 20/40 to 23/20. And there were 2 aflibercept arms. One got it monthly, and one got it every month for the first 5 months, and then every 2 months after that. And it was the control group received focal laser photocoagulation. And this is a busy slide, but basically the anti-VEGF eyes, the aflibercept eyes, did better than the laser eyes with similar visual improvement that we saw with the other anti-VEGFs of about 11 letters. 50% of patients gaining 10 or more letters, and about 30% gaining 15 letters. And this is just kind of an anti-VEGF summary slide from the DRC. You can't compare between trials because there are different patient populations, obviously, but you see kind of common trends in all of these eyes. Which anti-VEGF is best, we don't know. There's a protocol going on now, the DRCR Protocol T, that we're involved in, and we'll have some data on that sometime in the next, probably by next year's Academy. And it's designed to compare the safety and efficacy of bevacizumab, ranibizumab, and aflibercept in macular edema patients. Anti-VEGFs are great. They've revolutionized our care. But just a caution, we have 40 years of follow-up on patients who've gotten macular laser photocoagulation for diabetic macular edema, and we have to be vigilant in following our patients because anti-VEGFs do have ocular side effects as well as potential systemic side effects that we'll be uncovering, I think, as we move forward. So just to summarize my presentation, there's no one study or series of studies going to give us the absolute right answer on each patient, but these well-designed trials do help us in our management of these complicated issues. Each eye and each patient is different. The needs of a 40-year-old neurosurgeon with diabetic macular edema are different than an 80-year-old who doesn't read anymore. And treatments should be determined based on each individual circumstance. And Arch and Judy are all about family, and I just wanted to share my family with you all. I'm very proud of them, obviously.